Good morning, George. Is another beautiful Tuesday morning. I will be seeing you a little later on Long Island for a great foundation gala with our friends at Allied Physicians.
Yes, I'll be there too, waiting for you to come, and then we'll go. So today we have another wonderful guest, Dr. Chan. And the topic of discussion for today will be why doctors aren't going into pediatrics anymore.
Dr. Chan is a pediatrician in Washington, D.C., and a dual major with an MD and an MBA in health management and policy. Interested in a career that integrates healthcare strategy, emerging health technologies, and making a scalable impact patient care outcomes, access, and equity. Welcome, Dr. Chan.
Good morning. Thank you for having me.
We always start the show by asking people, why did you become a pediatrician?
Great question. When I went into medical school as a pre-med, I thought I wanted to become a neurologist. And as medical school went on, did all my pre-clinical clerkships, got through the rotations, I realized it wasn't so much the scientific specialty that I was particularly interested in. It was the demographic of individuals that I got to work with that was really what propelled me every morning to want to wake up, go back to the hospital, working with families, the educational piece that you get to have when you're a pediatrician, making joint decisions with everybody around, advocating for kids. It was something that just really clicked in med school that I wanted to do. And the other piece was, and I thought in retrospect, I was like, yeah, I've always volunteered for summer camps, after school care, daycare type of things through middle school and high school, and just really enjoyed it. And I think it all just clicked for me. And I'm really happy to have pursued it.
That's awesome.
Why did you do the MBA? Because you
Yeah.
look very young. I would think an MBA should be done a little bit later in life.
I was inspired by, I would say, luck and inspiration. The luck part was the fact that University of Miami even offered this program for the med students. So there was a recruiter that came over, had a little info session, and it piqued my interest a little bit because it was focused on health management and policy. So I went to that info session. The inspiration part was as I was rotating through surgery, internal medicine, OBGYN, all of these clerkships, I started noticing when I'm talking to a lot of my attendings and even the chairs of departments, they were going back to get their MBAs in order to take that next step up in their careers or gain some knowledge that they didn't when they went through medical school and then through clinical training. And when the opportunity came, I was like, you know what? I'm still in school. There's a scholarship involved. It's an extra year after my third year, between my third year and fourth year, that would be dedicated full time. I'm interested in this knowledge. Let me do it now because I'm seeing these attendings and all these program directors who are trying to balance a full-time job, their family, and then going back to school. And I'm like, let me nip this in the bud and do it now. And I'm really glad I did.
Awesome. Yeah, but I was very interested in your bio. In one respect, was I could never quite wrap my head around how you can implement this into medicine. But you have a Six Sigma belt designation,
Mm-hmm.
and you use that to improve the care of obese children.
Mm-hmm.
Could you tell us, for those people who don't know what a Six Sigma process is, what is
Yeah.
that?
So Six Sigma is this process improvement framework that I believe was created in the 60s. It was conceptualized and first used by the Motorola company. So the idea of Six Sigma is six standard deviations, meaning everything that you produce and the services that you bring out are going to be within what you want, hitting the target six standard deviations of the time from average. So that only, I think it's about 3.4 defects or 3.4 misses would occur out of every 1 million productions. And so it's just this framework to continually try to make your processes better, more optimal.
I think the company that best signifies Six Sigma in modern times is Toyota. And
Mhm.
I can never understand how you translate that process to taking care of people because
Yeah.
what they do is they eliminate any and all variants.
Mhm.
So the tools that the machinists use are all the same. The bolts that they use are all the same. The process is all the same. And so there's absolutely no variance.
Mhm.
This was best explained to me by a technologist, a computer engineer, because I'm a Mac person And he said, "Why are you a Mac person?" I said, "Because I don't know how the thing works underneath the hood, and I don't want to know. I don't have time, but it works." Instead, I buy Windows machines, and all of a sudden, one works, the other one doesn't work, and it's just so frustrating.
Yeah.
And he said to me, "That's because Dell machines, Lavoto machines, H&P machines, they're all the same specs, but they're just in time. So you might get a Dell machine with a different hard drive, and you bought them the same day, they just shipped 30 minutes apart. And that will cause some variance, and that will cause the software not to work properly." And in humanity, I sometimes have a black patient. Then the next one's Hispanic, one is obese, one's skinny, one's tall, one's short, one likes to eat vegetarian diet, the other wants to eat steaks. It is just humanity's full of variance. So I can't
Yeah.
control that. I can't eliminate that. And my process has to pivot depending on what patient I have in front. How do you apply Six Sigma when your product, the patient's completely variable, minute to minute, room from room?
I don't think it's necessarily applying Six Sigma to its T and seeing patients as a cell phone or as a computer. It's the framework of how to go about analyzing the process, making the process better, and then measuring after. So the core tenet of Six Sigma of how you go about this whole improvement process is something called DMAIC. It's an acronym. So define, measure, analyze, improve, and control. For a product, the idea is to finally get to a control to make sure every single product comes out the exact same. But for people, you're not going to get to that. And I think that's where the translation of DMAIC into what for healthcare is more PDSA cycles, that plan, do, study, act cycle allows for more variance in the types of people you're dealing with, more variance in all the workflow things that are going to happen that are going to be different from patient to patient through your process. And then you're just trying to hit that target. So it was more about, because I had my green belt, because I've had the formal education of Six Sigma, it was very easy to then grasp the PDSA cycle idea and come up with primary outcomes, secondary outcomes, all those metrics that we should be measuring and planning for that. And then using run charts, P charts, control charts, all those charts that are used in Six Sigma, they get translated over to the healthcare sphere so that we are now using the, let's call it USPSTF metrics that we're trying to hit, healthy people metrics that we're trying to hit, making sure that in pediatrics, bright futures, all those screening guidelines and prevention measures, that our processes are hitting those things that we're trying to do. I used it a lot when it came to the childhood obesity management project that I was working on. And how I did that at the time, I started this project between 2021, 2022. So the 2023 clinical practice guideline actually didn't even come out yet. But what I saw was that our practices, patients weren't coming back for their follow-ups. When you had a patient see one primary care provider for one annual visit, come back later for the next annual visit with a different provider in the same clinic, the notes weren't standardized. So I couldn't see what recommendations were given. I couldn't see what is that next step? What is that next motivational interviewing technique I should use? I figured out what change concept I can implement. In Six Sigma, in process improvement, there's these 70 change concepts that are taught. Some of them are leveraging technology. Some of them are making the space more efficient. Those are just little examples. I was using those types of change concepts into the practice workflow for us to try to better manage these patients.
What happened? You looked at it, you did a lot of fancy stuff,
Yeah.
but did you change human behavior?
We changed how we practice. The documentation improved. The note taking of what recommendations were made improved quite significantly. And then we also changed the act of when you make the follow-up appointment. One thing we noticed was that a follow-up appointment, usually we relied on the patient to call in to make that appointment. And we try to change it so that before they left the visit, they make that follow-up appointment if we recommended it. We message the front desk registrar. We tell them, hey, I want to see this patient in 3 months. For residency, a lot of us didn't have our schedule set for 3 months out or 6 months out. And so we had to do some administrative work on the back end to make that happen. There was
Okay.
a little uptick in patient behavior in making those appointments. And then I graduated residency and
All
wasn't
right.
there anymore.
But did 1% of the kids that you were following that were either overweight or obese
Mhm.
lose 5% of their weight?
We didn't even get to that stage. We were looking more at the proxy outcome of coming to their follow-up.
You mentioned something that irritates me to no end, which is called bright futures.
Mm,
It just triggers me. There is an office near my parents' house in Rockville, Maryland, that is
mhm,
a bureaucrat, and he's a government employee, and his team produces these guidelines without the consent or the acknowledgement of practicing pediatricians across the country. Then they pass it on to a committee in the AAP, which then endorses it.
mhm,
What the Bright Futures calls for, as far as doing it every visit, takes so much time that it would take the average primary care physician 23 hours to complete, which is impossible. And more concerning to me, the younger pediatricians are so focused on that piece of paper that they forget that the most important thing that you do as a physician is listen to the patient,
mhm,
address their concerns, be there,
mhm,
build the relationship. If you're concerned about how many check boxes there is in Bright Futures, you're not concerned about the mother, you're not concerned about the child. And that's a travesty because it's really taking the pediatricians and the family doctors out of the game of relationships and out of the game of autonomy and turning them into checkboxers with, as you said, with your study. I checked all the boxes, but did anybody get better? Measure that.
Herb, you blame the bright futures. I don't quite blame the bright futures directly because even the folks that wrote the bright futures said it can't be done
And
realistically
then why do you write it?
because they're academics and they have to write things.
This is a
I blame the computer companies and the residency programs in the medical schools. Okay. Because they brainwash her and they put this into the doctor's head that all this has to be done at that visit. They're not capable to freestyle and just talk and have a relationship.
they don't.
Okay. We invented that program, Herb, where Dr. Scott and I recorded these videos of about 5-7 minutes where we deliver as much of the bright futures that we thought was appropriate. And we send it as a text message and we have the patients watch. I said, did you get a text message that the doctor said to watch his video? Most of the time they say yes. Then I'll ask them who's on it to make sure that they're not lying to me. And then when they say it's me, I say, who's the other guy to catch them? And most of them appreciate it. They take screenshots of the PowerPoints we put on it. So we deliver the information. And then I just talk a little bit about different things that I think appropriate for that relationship. And we're done. We move on. It made my life better. Back in the day, Herb, what did you write on your progress note by hand? Anticipatory guidance, safety and feeding given, right? AG, safety, feeding done. That was your
I
note.
I had check boxes, feeding checked,
Yeah.
elimination checked,
Yeah.
and then at the bottom, anticipatory guidance given.
Better, more efficient.
I
Yeah.
always put red reflex times 2. They had, if it's a boy, testicles down times 2, and if it was a young baby, hips 90-degree abduction.
Yeah.
The things I could get sued for missing, and then done. Next patient.
Yeah, I was gonna say,
Yeah.
maybe I am brainwashed, and I can't argue against what about how it was created or whatnot, but I can say that when you look at something like Bright Futures, or when you look at some of these just guideline based, hey, you should do this, it does sometimes serve as a reminder to say something because
Yes.
I do feel that when you are just free riffing your visit, you can get carried away with one conversation. And then, unfortunately, because we do have to see the next patient, you have to see the next patient. You don't want to miss certain things in that beginning. Let's take maternal depression, for example. I don't want to miss asking those questions because I was carried away talking about breastfeeding and all these kinds of things. Maybe it's not a question that is going to bear that much fruit, but I have had instances where it's the last thing I'm like, oh, I am like prepping the vaccines. I didn't ask this mom that, forget what acronym for the 2-question screener was. I just went back and was like, hey, I sat down. I was like, oh, you just had a baby or you're a month in. There are questions that I just want to make sure like how you're feeling and things like that. and then I uncover something brand new. And now, do I have the next 45 minutes to start talking about this all over again? Not necessarily, but I want to plug her into the resources. We had a care coordinator. I can plug her into the right resources. So sometimes I do think that these standard guidelines give us a little bit of a reminder to standardize and make sure that we have the same conversations with everyone and give like that equitable care.
You see, that's the problem of burnout right there. It'll delay things. You have to set up processes where you can do your job.
Yeah.
And then when that problem comes up, I had a kid yesterday, came in for a checkup, left suicidal. I've discovered that in the first 30 seconds. Okay.
How was he?
On the PHQ-9, and the kid was the way they were talking and the way he was acting, and it filled out PHQ-9. I want to kill myself most of the time. I did my job, and then I figured out what's going on, and I sent him to the emergency room. Psychiatric.
That's exactly the PHQ-9, for example.
Yeah,
the
that's
screeners.
fantastic. Yes.
That's how you try to leverage technology and leverage
Yes.
other kinds of things to make sure that your workflow when you're
Yes.
talking to the patient and
Right.
the physician
Right.
is streamlined.
But I'm not asking the individual questions for the patient. I had
Yeah, I
technology
agree.
when I saw the affect of the patient and the parent.
Absolutely.
That's experience, Herb.
Yeah, I had dinner last night with someone who I really admire. He's the chief of pediatric gastroenterologist at both Children's National and Fairfax Hospital, and he's the CMO of the pediatric specialists of Virginia. And we're talking about stories. Most of the time, the parent tells you the diagnosis.
Yeah.
You just know how to take that. They tell you the story that says what the diagnosis is. And as a doctor, all you do is you plug him into the right system. It could be, it's strep. I have 3 kids, 2 of them have strep. The third one's now having a fever. Okay, you got strep. Let me give you your antibiotic. Or my kid's losing weight. You're peeing all night. He's eating the whole refrigerator. I'm afraid he's got diabetes. Oh, let me get the glucometer. Let me see what it is. Oh, dear. It's too high to read. I need to get you to the peds endocrinologist. But the importance of medicine is listening, in our case, to the parents who tell us the story. And often they give us a diagnosis.
And in this particular case, the mother said, I had him fill out the form, which is the right thing, because I wanted to hear. She knew that the kid had a problem. She just needed to bring it to my attention.
Someone to give her the space to tell the story.
Yep.
And that, I think, is where you find that you can help.
Mhm.
If you don't give them the space to tell the story, you just dump a bunch of pre-recorded in your brain checkboxes.
Yep.
They may have some real concern that needs to be addressed, and you didn't give them the space to tell the story.
And let's move on to the
think I'll
topic
look
at
at
hand.
AI. What do you think are the main factors contributing to the decline of medical students choosing pediatrics as a specialty?
Yeah. I think it boils down to reimbursement. It boils down to salary. When you're in medical school, you're taking on an average of over $200,000 in medical student loan debt. So when you come out and you're looking at the salaries for different specialties, and the 6 out of the lowest 8 salaries are all pediatrics, it doesn't make you feel like you're going to be able to sustain your own livelihood, your own family, pay off this debt, especially with rising cost of living in most major cities all over the country right now. And so you're going to be looking for some of the other specialties that pay you a little bit more. In addition to that, it's the burnout, it's the administrative burden. Pediatrics is, a lot of people still think, generally, when you think pediatrics, you think of the primary care pediatrician, the general pediatrician, and it's comparable to family medicine. Every hour you're spending with a patient is 2 hours on the EMR. And so that level of administrative burden combined with the low reimbursement, it doesn't inspire people to want to go into it when you're carrying that much debt and you've worked that much harder. And also, people are knowing more and more about how long the training period is. So in most pediatric subspecialties, and I'm not an expert on why this is the way it is, most pediatric subspecialties is a 3-year fellowship. Whereas in adult medicine, you're done with internal med and it's either a 1-year or 2-year fellowship. And so you're actually training more to earn less. I think that's one of the major contributors.
Yeah, I think of the fellowships, there's 1 year of full research. That's why it pushes it to 3 years. In the adult world, They have procedures. In pediatrics, there's not so many.
That's another.
Adult GI doctor does a whole lot of procedures. Pediatric GI doctor, if he does 1 or 2 procedures, is a lot.
Mhm.
In the pediatric world and or PCP world, we don't do a heck of a lot of procedures. When you
Yeah.
do a ward where you take out a gummy out of an ear or a nose, that's about the
Yeah.
only procedure you do. And if you take something out of the nose, they'll reimburse you a good chunk of change. Whereas
Yeah.
if you think about something, they don't.
Yeah. You talk 40 minutes about depression, it's not reimbursed as much as that earwax removal.
Yeah.
So
So,
it's a payment problem, and the payment
Mhm.
problem distorts everything, right? If you try to do simple lacerations in the office, you lose money. Just a dermal bond. I don't know what it's costing now, but when I used to buy a dermal bond, it was like $75 for every pen. And the insurance company for a simple lac used to reimburse me at $100. I'm getting paid $25 for my time. I would love to take care of more sprained ankles and simple collie fractures. There's no rocket science in that. It's pretty
Mhm.
easy. But the insurance company will bundle my casting and x-ray fee with the office visit. So now I spend more time, did better work, more aggravation, more hassle, and I get paid just the same as if I say, "Oh, looks like it's broken. Go to the emergency room." And then they're like, "You sent too many patients to the emergency room. What do you want me to do? You don't pay me to get the X-ray, put them on a boot, and then see him back in 2 weeks and re-X-ray them and order their PT."
yeah, my
I s
wife, when she went to the ER for a sprained ankle playing pickleball last year, you know how much reimbursement was? $3,000. So if they came to the office, that would have been $100.
$100. They would have bundled everything. You have to use a C-arm because you can't afford to have an X-ray tech sitting around doing nothing to get these X-rays. So they make it so we can't really provide the care we want to take care. I also think it's a payment problem that what I call the support clinicians are not paid enough. So the dietitian, the psychologist, the care coordinators, the social workers, the pediatric endocrinologist, the pediatric neurologist, the
Mhm.
pediatric
Mhm.
behavioral health subspecialist, they're nickel and dime too, to where it's not in their interest to see insured patients or to be in that subspecialty.
Yeah.
And so you do the work you're supposed to do. You diagnose a child that failed the MCHAT, looks like he can't make eye contact, his speech is delayed, and you want to send him to see a behavioral therapist. The waiting lists are for in around DC area 2 years.
Yeah. Yep.
Oh,
In New
and
York, it
then
was 6 months, I remember.
and then they tell you, you know what? Go ahead and order the ABA, the occupational therapy and the speech therapy. And I'm like, with what diagnosis? And how do I know that the ABA therapist that is going to her house to this kid is doing the job they're supposed to be doing? What
Mhm.
metrics do I use? I don't have any training to know whether the ABA therapy is being done properly or not. I can even direct them to do it because I don't know what they do. If you pay people enough, there will be enough behavioral pediatricians that do a 1-year fellowship. They don't need to do 3 years if they're going to be clinicians. And they come out and they're like, I'll write the script like an IAP. This is what I want the speech therapist to do. This is what I want the occupational therapist to do. This is what I want the ABA therapy to do. And send me the report so I can see that you're doing the work that the kid needs.
Yeah.
I said,
They
"Mm,
word on the
Mhm.
street has it by some people that the fee for service is the part of the problem of healthcare.
oh, good. You really want, why are you putting poor Dr. Sent through this?"
I guess for the procedures, yeah. You want to do a lot of hips because a lot of income is generated from hips and knees. But throat cultures, really? Somebody's going to get rich off of a throat culture? Come on.
All right.
Well,
So,
so I'm interested in hearing your opinions because I want to talk to individuals that are experienced in this. And for me, like grappling with the concept of fee for service versus
Uh-huh.
capitation, the taking on risk and all these kinds of things, like there is something that makes sense about fee for service works for certain things and it doesn't work for other things. To me, primary care doesn't work with the fee for service model. Is that incorrect to assume, in your opinion?
no,
Well, I'll hire you, my friend.
and the George's question is very good.
Yeah.
We have to start with the Obama administration. They did not have the courage, except for a sick man, to say, The problem is that we spend too much money at the end of life. We spend about $350,000 to $400,000 at the end of life for futile care. And until we address that, we cannot change the cost of care in the US. And he was the only one who had the courage to say it. And then he got enough death threats to shut up. Because basically what people heard is, you're killing my grandmother. She
Yeah.
paid Medicare her whole life. She deserves every damn thing that they can give her until she's dead, because she worked and she paid taxes for 40 years. Okay. So when the politicians talk about fee for service versus value based, what they really are saying is, it's a euphemism for, we can't afford to keep paying $1.3 trillion from the federal government, Medicare and Medicaid, mostly in the care of elderly people. That's what value based is. There's not enough money in there to get a contract because the spend is too small. So as long as we talk about fee for service versus value based, no care, what we're doing is they're distracting us so that we can argue about nonsense, and we're not changing anything. And then it becomes, this is a free country, and it's a very complicated country because it's a republic, but it's also a federation. The federal government only has the powers that are enumerated in the Constitution. Any other power not enumerated in the Constitution falls upon the states. That was because the founding fathers were afraid of the king in England. They wanted the people that govern you to be closest to you so that you can kick them out if they're not doing a good job for you. So it's much easier to kick the town of Leesburg's governor out or mayor for me than it is for me to get President Biden to leave the White House. I'm one of 300 million. There's only probably 20,000, 30,000 people that live in Leesburg. I know a lot of them. They're my neighbors. Okay. And so then it becomes, who pays for what that doesn't run afoul for the Constitution. And then we have history, which doesn't work for us, which is on the commercial side. Because of the Second World War, there was a freeze on wages, so people couldn't get paid more. And what they did is, the factories needed employees, and they couldn't pay them more because there was a cap on wages. So what they did is they added health insurance. And so health insurance is a tax on everybody, because that $35,000 or $37,000 that the partners RBK are paying to insure themselves and their families is money that can't go to give yourself a raise, or to give yourself a vacation, or to upgrade the office, or to give employees a raise, because it's being taken. It's a tax, a huge tax. So all those things play into, and then you play into the difference that is primary care in pediatrics, which is the interventions that we do that save the world, like the HPV vaccine, don't have a return on investment. And the reason they don't have a return on investment is because I vaccinated a 9-year-old. Maybe she's exposed to the virus when she's 25 and sexually active and doesn't get the disease. And so I can't prove the negative. I didn't save any money. She never spent any money.
Investment doesn't exist.
That's
It's
how
just
does it money?
Yeah.
And then
value is a euphemism for how much money did we save? Well, we didn't save any money. We spent $300 on the vaccine and $70 on the visit. We spent money. That's what they say, right? We spent, but we invested money. And so then it becomes a very difficult conversation there.
So who saved money? Which insurance company? Insurance A that put out the money for the vaccine, or insurance E that didn't have to deal with cervical cancer?
The problem there is that no one saved money according to them, because this year we spent whatever, $2 billion in taking care of women with cervical cancer. And next year we spent $2 billion. It didn't change. What they're looking at is, I spent $5 million for Long Island on congestive heart failure in 2023. Now, through these new programs, I spent $4.5 million. So I saved $500,000. That's what we're going to share between the people financing it, the insurance company, and the clinicians.
Mhm.
But when you don't get the disease, there's no savings in their mind. It's not a system that can be done for long-term investment.
Right.
And I compare it to educating children through K to 12, which we don't do a very good job at in most communities. And we spend a lot of money and we have absolutely no outcomes and no accountability. But no one says, in my county, Loudoun County, we spend $17,000 per student. We have great outcomes. In DC, Baltimore, New York, Boston, they're spending up to 35,000. In Chicago, only 30% of third graders read and do math at grade level. And they're spending $35,000 per kid. But the point is, no one says, how much money am I saving by spending $17,000 or $35,000 to educate a child? What's the return on investment? We say it's fundamentally important that we educate children. It's our future. They need a good, solid education so that they can be productive as adults. And the last part of it,
Yes.
the concept of insurance. Insurance is for big expenses. Otherwise, it's incredibly inefficient.
Mhm.
On the average, Medicaid in the US spends less than $3,000 per kid per year.
It's true.
So if you're having a $3,000 spend to create an insurance program to manage, that 15% is going to the insurance company, which is a huge bulk. Now, if you're talking about cancer therapy and you're spending $2 million, it's worth putting the resources to manage that care. And so what the American public is going to have to demand out of the American Academy of Pediatrics, the legislators, the policymakers, is that we come to terms with who funds childcare. And it should be universal and it should be at $300 a physical. It should be on a debit card, like most states already have for food stamps and for child support checks. We don't need an insurance company taking 15% of to manage what. We know a 3-year-old supposed to come once a year. $300 on the credit card. If you don't use it, you lose it.
Mhm.
Okay? Who pays for that? The federal government? I would argue it's the federal government's responsibility because I don't want the state of Mississippi, who can't afford to do that for their children, to say, we won't do it. We need to pay a per member per month, but without handcuffs. No more MOC, no more certified medical home, no more reporting process standards like BMIs or did I check that box? Because it's wasteful.
I think the reason that they did all that stuff was because you're going to have some people that will do the certifications, and it justifies moving the money from those that won't to those that do comply.
It doesn't have to be a huge amount. And the
Yeah,
point
but what do you do with practices that are totally transformed and they do all the right thing and the resources and referrals and computers and electronics, and you have those guys that are basically on paper?
How do
You have to
you then
certify somehow.
maintain some level of standard?
you guys have to, first of all, we have to make sure that the doors of the primary care doctors stay open.
Correct.
Can only be done if there is a per member per month fee across the board. Everybody gets treated equal, whether you have Medicaid, whether you have Blue Cross, whether you have Aetna, comes from the state. Your panel is 1,000 kids. You get X dollars a month to make sure you're available to take care of these kids.
Contract them?
Isn't that
No,
capitation?
that's
Isn't
not
it-
competition because you're getting paid $300 to do the physical. If you don't do the physical, you don't get the money. But
The retrospective payment in your system.
you're not rushing through 30 patients a day, but you have the time to be a physician and take care of the more complicated kids, do the care coordination, maybe hire a care coordinator because now you got this extra money, put the systems in place because you got money that's coming, whether you see the patient or not, to take care of them.
So you're saying fee for service plus
Yes. And then
That's okay.
that's not value based. And to your point, because I'm not measuring how much money I'm saving, because that's not a metric that should be used in the very, very young population. That is a metric that should be used in the chronic care arena.
Yeah, but in the young population, it's basically what you're supposed to do. Get in checkups, do the vaccines, do the lead test, all the things that are supposed to promote healthy.
Correct. But those don't save money. By identifying a person that has high lead levels and going through chelation and preventing harm,
Justify,
you don't save money.
how do you justify paying somebody? Why? I do a great job, you do a terrible job. Why should you and I get the same?
I think that should come from chronic disease management. And
30 years from now, the obese kid, 30 years from now, that has diabetes and stuff. Nobody knows.
Right now, other than Jim Riley, nobody's taking care of the obese kid in primary care because you lose money. So I think you're right. There should be an accountability, but the accountability should be simple. Metrics that can be measured very simply. You have a panel of 1,000 kids.
Well, we got to move on from this.
Hold on, because he wants to know the answer to this. You asked. You shouldn't have asked.
Don't blame me.
You have 1,000 kids, a panel of 1,000 kids. We know that you're not going to do 1,000 physicals because you're never going to get to everybody coming in. But maybe the average pediatrician gets to 80% physicals are completed. So on the chronic care global fee, they get average payment, $200 per patient. If you are 85%, kids come in for your physicals, you did 850, then you're above the 50th percentile, you get $250 per chronic disease management visit. And if you are the 95th percentile compared to your peers, then you get $275 per chronic management visit.
Yeah.
And the other things, which is two things that previous guests have mentioned as quality, which are easy to measure, which does improve and decrease costs without being unfair. If a kid calls in at 11 o'clock at night and they say they're having the most severe headache of their life, and they have 102 fever, what am I to do? Send them to the emergency room.
Right.
And that is having same day sick appointments. Those practices that can see all the sick kids the same day should be reimbursed more. The less that distance is, the better it is for patient compliance.
And this is called a quality incentive program. Capitation is not good. I just want to tell you, it's not good because they don't pay enough. And it's an incentive to keep the patient out of the office. If you don't want to see a patient, do capitation. Simple. DPC is different because somebody pays. All right. And they pay well. Yeah, I'll do DPC. 21,000 patients at $200 a patient per month. Wow. We got a lot of money, but it's not reality.
Yep.
Let's move on to the topic at hand, Herb. Let Dr. Chen speak a little bit.
But that was great. I appreciated the conversation.
Yeah, we triggered him.
Are there differences in work balance between pediatrics and other fields, Dr. Chen?
So, yes and no. I think it's just specialty dependent, right? Like you can compare a primary care pediatrician to a family medicine generalist, a primary care person. You can compare a neonatologist to someone in the adult world doing primary care. So I think probably work-life balance is a little bit better I think it's just dependent on the specialty and it is comparable.
Yeah. And it depends on what you like to do, because neonatology might work 24 on, and then I'd have 2 days off, and they're totally okay with that.
Hospitalists going 1 week on, 2 weeks off. Then again, a lot of times on the weeks off, they're not necessarily off. You may be having to do research for your center, your administrative tasks, and all these other things.
Do 1 week of days and then a week off, then 1 week of nights, 12-hour shifts. When they do those nights, they're not functional for half the week afterwards. It's just recovery. They need that time to recover to be able to come back. I'm more curious as to what a young person thinks work balance means. There never seems to be balance in life. Either you have young kids and you have no time, or the kids grow up and they leave, and then you're sad that you're never around. But it just never seems like it's a perfect fit. What does work balance mean to a young person?
I can only speak for me. I can't speak for the entire young person crowd. For me, it's having enough time to enjoy the rest of your life. Sometimes I don't even like the term work-life balance because you're very much delineating work and life as two separate entities. For others, it may just be very intertwined and you accept that. There are individuals that are going to work just to pay the bills and then they want to spend the rest of their time with their family. But there are others where work is me, I am work. This is my passion. This is what drives me. And this is the entire value system. So work-life balance is just going to be different for every single person. It's just how much you value one thing over another. For me personally, it's about having the time to spend with my partner. We are considering raising a family very soon. So am I going to be a present father for my child? And what does that look like? Are they going to be able to provide me that family leave or that paternal leave to be able to help my wife? Because we're a dual income system. Most people now are dual income households. It's not going to be just reliant on one person to take care of everything. And so I think that's what my sense of work-life balance means, is being able to take care of the rest of your life.
Yeah. I did some research on work-life balance, but I used to think work-life balance to a young physician meant I don't want to work too much. I want to work when I want to work and not work weekends. You need a flexible schedule. They want a flexible schedule, which is good. Short days, long days, but hey, we're physicians, so we have to work a little bit of nights, a little bit of weekends, because you're the generation of parent that wants to go to my office on Saturdays.
Yeah. Yeah.
Simple. You should provide it to a little bit. Reasonable work hours. I agree with that. I don't want to work until midnight either. You should have adequate staffing to help you throughout your day.
Mm-hmm.
Many places you're on your own. How many offices you have with a pediatrician is the only one there, a medical assistant to help move some stuff, have to give their own shots, make their own appointment. You should have time management help. Basically, what does that mean? Using technology and infrastructure to help you to get through your day, right? You should have a supportive work culture of your superiors, your senior physicians. We have to work together. Not you should do all this because I did it when I was your age. You have access to resources. How many practices work in the middle of nowhere and they have to go in the middle of the night to the emergency room to do a spinal tap?
Yeah. Yeah.
A lot.
I think you missed something very important, George, which is that the technology doesn't help. The phrase they coin it now is the pajama time. You just cannot have your clinicians go home to their families. That's their time.
Yeah.
You can't have them open up the bottle of wine, cook the meal after they work, and then sit in their bed with a laptop
I agree.
finishing their charts.
It was very interesting when we had new physicians join us. They all want access to the EHR from home. And I tell them, you shouldn't have it. I can give it to you.
But out of necessity.
I recommend you should not have, there's no reason for you to chart at home. Your technology should be good enough for you to be done when you go home. That's it, done.
Yeah. I want that.
Yeah.
When I was in residence, in my personal life, an example, my wife's a lawyer. So when I was in residency, she would be working a 13-hour day just as much as I work a 13-hour day. And we come home, no one's cooking. I'm thinking about my colleagues who had 2 kids going through residency, the same as me, with a partner who was also working. Like, they have to cook. There's a child, there's 2 children. But after I'm home, I'm actually still charting and doing progress notes on the patients that I saw during the day. Now, of course, it's residency and that's a different dynamic. It's not the same as when you're a full-on attending or going into primary care. But I like that pajama time is a very real. It's an unfortunate.
It's a byproduct.
Reality. Yeah.
It's a byproduct of the system. It's a byproduct of the physician that could be inefficient. I never charted home, ever. Zero, not a possibility.
But we also forget, because like vaccine preventable diseases, we don't see them, so we don't fear them. But before our time, George, people will bring their kids to your porch. And that was the norm.
Yeah.
Johnny got sick. They knew where you lived, smaller communities.
Didn't happen. They said it probably happened before my time. But that
that's what I'm saying. Before your time, the partners that started the practice in Long Island.
It was a small community.
People would knock on the door. Johnny's got 103 fever. You doc, what do you think?
Yeah,
I wonder in that scenario, though, the doctors in that situation, we're not getting burnt out by it's not a scenario where I need you to be on a computer. I need you to
Right.
type things up. You're actually like, if Johnny comes over to my porch, I chose to be a physician and I'm like, I'm going to help Johnny on my porch.
Yeah.
Yeah.
But that doesn't contribute to my burnout the way that I need to go on my computer and type progress notes right now.
That's the
Contributes
problem
to my
right
burnout.
there. That's the problem
And,
right
and
there.
and the other thing is they didn't judge you. They knew you were home. If you were having a bottle of wine with your partner and they interrupted your dinner, they apologized and they were like, "Oh, you've been drinking. You can't see my kid. It's 7 o'clock at night. I have a partner and a right to have a meal with her too." They
Yeah.
were like, "No, we don't care. I just need you to eyeball Johnny and tell me it's okay."
Yeah.
And yeah, it's fine. And then our generation, George, dealt with the mommy calls,
Yeah, I know.
which was horrible. If you were covering a large group, as soon as the doors closed,
The
they
phone
would
rang.
stop calling one after the other. That's largely gone away, thank God, because
They're all
it was
calling.
just, and then they would wake you up at 2 and 3 and 4, and then you had to be in the office around at 7 and be at the office at 9, and you were like, what is these people from science fiction that walk
Twilight
around?
Zone.
Yeah,
Twilight.
I have a question for you. I know you haven't had a 20-year career, but how do you think pediatrics is changing? Because I feel it's changing very rapidly.
Yeah.
And what are the opportunities in that change?
There's definitely a shift in the patient population that we're working with. As the country continues to develop, the immigrant population, the Hispanic population, the Asian population, they're all growing. That tells me that the people providing those preventative care visits, having those deep conversations and forming relationships with their patients, need to also be representative of that patient population. And so I think the dynamics of the workforce and who's coming in needs to make sure that we're having the right representation in the workforce to work with the patients that the patient shifts. That's from a demographic standpoint. The diseases that we're working with are also shifting in pediatrics. We're getting really good at a lot of the acute care situations where a lot of children with rare diseases and complex diseases are being able to live longer, which are all great things. But that means that as pediatricians, as their PCPs, there's a lot more complexity that comes with managing them. And if there's a shortage of specialists, there's just no access to that developmental behavioral pediatrician. There's no access to the geneticist, all these kinds of things. We need to leverage technology, integrated care, collaborative care models, private public partnership. We need to leverage these types of things so that we can do the best we can with the cards that we're dealt.
And I always say we live a sheltered life in Long Island because we have everything. They're shorted physicians, but they all want to come to Long Island and New York
Yeah.
City. Nobody wants to work where there's a need.
Yeah. I think there's just a lack of optimization of where the pools are. And that goes back into reimbursement too. A lot of the rural hospitals, these critical access hospitals, they just get reimbursed less by private insurance. The small rural hospitals get paid less by commercial insurance than how they pay urban centers. And then that just creates this vicious cycle of not being reimbursed enough. So you have to cut costs. If you cut costs, you're not going to be able to deliver better care with that. And it just continues until the doors close. And that allows corporate medicine, that allows insurance companies to come in, buy out these centers and do whatever they do. And they're just a cycle. And it just keeps going down that way.
So with all these organizations buying out, all they're doing is you're taking a loan, you're paying Herb off to give me his practice and to go away without talking. I hire you at half his price. You do that for a little bit, and then you become Big Herb. Somebody else buys it out, they give it to you, and they just keep flipping it. There's no quality in that. How many urgent cares are like that? They've changed names 5 times in the past 10 years.
Yeah. The problem is also quality of life and the fact that for most US households, you can no longer live an upper middle class lifestyle if you don't have a partner that works. For example, you said your wife is a lawyer. Let's say you were going to want to take over a solo pediatric practice in Topeka, Kansas. There's no jobs for the kind of law that your wife practices in Topeka, Kansas. So that makes it an absolutely no.
Yeah.
You have to be in a city of a certain size. Somebody else may be married to an ophthalmologist. They need to go where they can find a job for the ophthalmologist and the pediatrician.
Mhm.
And that means a certain size of a city. And then the real problem with this idea of JDEI, in a little way, is a little bit insulting because I'm Spanish. And I don't think a white man has the right to tell me that I have to go to Texas to take care of Spanish speaking kids. I should go where I
Yeah.
want to go and practice where I want to go.
Yeah.
If I feel that it's my mission to just take care of Spanish speaking kids and I want to do that, that's great. Who has the right to tell me I have to go
Yeah.
back
Yeah.
and take care of people that look like
Yeah.
why? And if that wasn't bad enough, they can't make money. You go into a poor neighborhood, maybe you grew up in that neighborhood, and it's all Medicaid. The school system is broken down. It's dangerous for your children, your family,
Mhm.
and you can't make ends meet. And
Yeah.
you put all this effort to educate yourself so that hopefully you could give your children a better childhood than your own.
Yeah.
What we need to make sure is that everywhere, urban, poor suburbs, rich suburbs, rural, every child has access to a pediatrician or a family medicine doctor, and that it is paid at the same rate so that there is money to do the job. That's really what the conversation should be about.
Yeah. Yeah.
We cannot leave any child behind in any community. Forget about what their clinician looks like. Let's give them access to begin with. Then we'll worry about all these niceties. But what good is it to talk about JDEI when pediatric practices, maternity wards, pediatric emergency rooms, critical care access hospitals are closing in droves all throughout America? And now you got no care for
I agree.
no
I
cost.
agree.
We do because they don't.
Yeah. And I agree with that from the access perspective. That's the number one priority. For me, it's more of, I mentioned that second grade career day example. It's all the barriers that happen from that state of childhood through obtaining medical education, through getting into residency, that are bigger barriers for certain populations than others, whether that's the ability to pay for an SAT tutor or just going to a good school, all those
Is-
kinds of barriers. That is my angle of wanting more representation in medicine by inspiring more of our future physicians.
And I think that when I talk to leadership, I go, we don't need every child in Medicaid. That's wrong. What we should be saying is no child should live in poverty. Every child should have access to a decent education so they can pursue their dreams.
Yes.
That's what we should be talking about. Lift every child out of poverty. I know it's not possible, but that should be our stretch goal, our
Mhm.
inspirational goal. And every child, I don't care how you educate them. I went to Catholic schools, private schools, send them to the private schools, send them to the public schools, send them to the charter school, magnet school, whatever it is, but educate them so they can pursue their dream because that makes us stronger as a country. Every child in every neighborhood.
That's the problem.
Yeah.
They want to live in cushy Long Island.
Yeah. Because they want to see their kids be raised in a good school and in a
Yeah.
safe environment.
Human nature. Nothing wrong with
Yeah.
that.
They don't
But
wanna sleep on the floor because 'cause they're worried that there'll be a drive-by shooting.
yeah, you know what? In my office, we have access to care. I am your white dude that speaks Spanish, that sees Asian people, that sees the brown community, that sees the Afro-American community, that sees the Jewish community, the Catholics, the whites. I see everybody. I'm a doctor. Simple as that. I am a physician. I don't care what insurance you have. Come on down. That's the way it's supposed to be.
We made the system too complicated and
Yeah.
inefficient, and it's not serving our society value
Yeah.
based, whether your physician looks like you, and social determinants of health. Well, the reality is, if our aim is to lift every child out of poverty and give them a good K through 12 education and access to a pediatrician or a family practitioner in communities where a pediatrician cannot sustain themselves because it's too small, we will do much more good than continue to have these conversations.
We just implemented this social determinants of health,
Yes.
and I was surprised at the amount of positive responses that we found. But I think the purpose of it is if, they have problems going to get into medical care, you should give them some information on how they can find a taxi service that Medicaid covers. If they have problems finding food, you should give them information to soup kitchens and WIC to be able to get food stamps. A lot of people don't know. I
Look,
think
they don't even
that's
know.
the purpose. I think that's the purpose of social determinants of health. But putting it in front of the doctor to deal with it, that's where it gets complicated. They have no time to deal with it. So you have to put somebody at a lower level to look through these things and sift out all the 80% that are without any issues, find the 20% that do have issues. It could be a nurse, it could be a medical assistant or somebody to hand out information. We have to think it and say, okay, these are the packages that you have to give if this is positive or that's positive. But unfortunately, a lot of people don't even know what WIC is. So I think
Yep.
it's our job to just give them the phone number of WIC to go get food stamps. They don't have insurance. They need to have a way to get insurance because they don't know how. If the child thinks he's being physically abused by the parent, so when they come in to call Child Protective Services to deal with the situation. But the way they're created, it's this big checklist of things thrown in front of the physician. They're supposed to check and look. Of course, they're going to have physician burnout.
But that's where your care coordinators are, and that's where that fee that I was telling you per member per month
Yeah,
sustains that because it's not
right.
based on people coming in.
Correct.
You got your care coordinator making sure that Johnny went to see the orthopedic surgeon, making sure
Yes.
that Johnny made it to WIC, and just constantly touching the highest risk, the most vulnerable, the most in
Correct.
need
Yeah.
population.
Yeah,
Hopefully,
now in New York State, they're starting to cover this thing called a community health worker. It doesn't have to be a licensed anything. It's like a care coordinator, referral person, population health person. They're supposed to outreach to get all these referrals and get. Some people can't even. I'll give them a referral. They have no idea how to pick up the phone and call and get an appointment with Dr. Chen. I had one lady that unfortunately spoke Spanish, and the kid had trouble getting through to her endocrinologist when the kid had a blood sugar of 600. She didn't know what to do. She had the sliding scale. The doctor told them everything that they have to do. She has the insulin pump, but she's missing some piece to connect it. I said, really? I find that very hard to believe. Let me have the phone number. I called the phone number. It was in English. She spoke Spanish. If you follow the Spanish prompts, it would get you to an emergency number to call the endocrinologist. She's mad at the system because she didn't know how to go through the system. She just needed education on that. Now, was that my job? I don't know, but I did a good thing and I told her how to do it. And we called and I went through the process and the endocrinologist called.
we see it too with asthma, right? They send kids from the emergency room with a meter dose inhaler
Yeah.
and no aero chamber, or they give them the aero chamber. They never tell the parent that they got to wait till the kid takes 10 breaths.
Yeah.
They don't give them a YouTube video to watch. I have them come in with the inhaler and I watch them do this. And then all the smoke comes out of their mouth, right? They're not getting any treatment. No wonder they're landing in the ER.
Yeah.
And that's where having this money that comes into the practice to create these systems so that you're not rushing through that patient, keep them out of missing days in school, keeping them out of the emergency room, keeping them out of the ICU. That's very valuable. But again, you're not going to show cost savings.
Yeah.
Which is what value medicine is predicted on. So the conversation needs to shift to how much money do we need to invest in early preventive care that will 30 years down the line decrease the cost of all these chronic diseases.
Yeah.
That's one piece. And then the other piece is those who are unfortunate to have severe chronic diseases, given better managed medicine so that they can get the services they need without having to always end up in the hospital for that care. That's where you can save money and improve quality.
I think the asthma example, I will say, is one where I could see a measurement, because if you were to invest in the salary of an asthma educator or two, and you implement something like an asthma action plan, going from not using one to using one, these are things where you have a measurable investment amount. And then you can look at your patient population's ER visit rate, your readmission rate, how often are they coming back to you for asthma exacerbation as a diagnosis? And there are cost amounts that get tied to this. So I feel like there are ways to measure certain situations.
Disease management, yes, but preventing, no. So I was just at a talk where you can give a monoclonal antibody.
Oh, yeah. I think it's the brand name.
For kids with asthma, if they have allergic asthma, the classic with allergic rhinitis, and they have eczema and they wheeze with every cold, and you improve their FEV1s and you decrease the amount of steroids you need to give them, and you decrease the amount of ER visits that they get. But it costs $30,000 a year. So
it messes up your value-based contract.
If maybe it is worth spending the $30,000 to get this kid to stay in school. So that's what I'm talking about, value-based.
Yeah.
When you prevent something, you spend money and you don't necessarily save money.
Unfortunately, in value-based in pediatrics, unfortunately, there's not enough money attributed to a kid to offset that $30,000 spend on that medication.
There isn't.
I've been dealing with value-based. The new game is take the peds and dump it into an adult medicine value-based contract. Because what does that do? You could do some shared savings on the adult side, and then the kids fall into the value-based at a per member per month fee and value-based care. And the ped always manages to pass the quality programs, and it dilutes the adult side. And then there's shared savings, and multiply it out by the million kids that they have in the program. There's good money for some MBA somewhere.
Dr. Chen, thank you very much for joining the show today.
Last question, Herb. What advice would you give to a medical student who's on the fence about choosing pediatrics?
Ooh. Choose your specialty wisely, but if you're thinking about pediatrics and you like working with kids and you like, absolutely, I think pediatrics is a slam dunk option. The value and fulfillment you can get when you're lockstep in sync with the family, advocating for their child and making sure that we're all on the same page. We're making sure your child's going to grow up healthy. I don't think there's anything better than that in terms of satisfaction.
We're the rock stars of medicine. Everybody, we're the most popular physicians.
It's the greatest ROI. The healthy kid that comes up, grows up healthy.
What do you think?
I went into pediatrics because I love pediatricians, but also because my patients were a blank canvas.
Yeah.
You never knew what you were touching. You could be touching the next garbage collector, or you could be touching a phenomenally talented artist that will become world famous, and you have no clue. But
I heard in our office, Rosie O'Donnell
there.
used to come to our office.
Who did?
Rosie O'Donnell. Yeah.
So you don't know the potential. It's a blank canvas. You get to make sure that canvas is solid.
Yeah, absolutely.
And that is the dream of pediatrics.
Yeah.
Thank you both. This is a great conversation. Learned a lot.
Hope to see you soon again.